Welcome to Chapter 13, where we will be reviewing a various assortment of environmental emergencies. So, when a person is exposed to excessive heat, body mechanisms for regulating temperature can be overwhelmed, resulting in heat cramps, exhaustion, and even heat stroke. Exposure to cold environments may result in conditions such as frostbite or hypothermia. Unintentional exposure to water can lead to submersion injuries and even drowning. As you're approaching a patient exhibiting signs and symptoms of an environmental emergency, you should always try to follow the primary patient assessment sequence as best as you can. Review your dispatch information prior to arriving on scene if possible, keeping in mind that you're not always going to find on scene what you were dispatched to. Assess the scene to determine safety issues for you, your partner, or the patient. And then as you're performing your primary assessment, try to formulate an impression of the patient's condition, determine the patient's level of responsiveness, introduce yourself, assure the presence and quality of airway, or the patency of the airway, breathing status, and then the rate and the quality of their circulation, or their pulse rate. Acknowledge the patient's chief complaint. It is usually best to collect a medical history using the sample acronym for your history collecting before you perform your secondary assessment. Your sample history format includes signs and symptoms, allergies, medications, pertinent history, last oral intake, and then the events leading up to or associated with the nature of illness or injury. Then, of course, your secondary patient assessment focuses on areas related to the patient's current illness. The patient may not always be aware of all various aspects of his or her problem. Obtain vital signs from the patient, and then monitor the patient through the use of ongoing reassessment tactics if arrival of additional EMS personnel is going to be delayed. So we have the three forms of exposure to heat. First off are heat cramps. Heat cramps are painful, involuntary spasms of muscles. They often occur after exercise, especially in hot weather. The exact cause of heat cramps is not really known specifically, but it is thought to be related to partially to the change in electrolyte balance that occurs during exercise, or partially to dehydration that accompanies exercise or working in a hot environment. Remember, as humans, we're notoriously already slightly behind the 8 ball or dehydrated at rest. So when we go into a hot environment or we begin working out or working excessively, we're already dehydrated and we're not helping ourselves out. These occur more often in the leg or calf muscles. When abdominal cramps occur, it may appear that the patient is having acute abdominal problem. Treatment of heat cramps. Move the patient to a cool place, get them out of the environment that they are currently in, have them lay down in a comfortable position, give the patient water to drink. If the cramps do not disappear, or if the patient is young, old, or has a chronic medical condition, arrange to have the patient transported to an appropriate medical facility for further evaluation and monitoring. Heat exhaustion is moving a little bit more down the severity line. This occurs when a person is exposed to temperatures higher than 80 degrees, usually in combination with high humidity. It can also occur as a result of vigorous exercise at low temperatures. Signs and symptoms of heat exhaustion include profuse sweating, lightheadedness, dizziness, nausea, weak pulse, and low blood pressure. Predisposing factors may include some people are more susceptible to heat-related illnesses, including very young or older patients, typically greater than 65 years of age, pre-existing medical conditions, certain medications, high air temperatures, or high humidity, which reduces the ability to evaporate or exchange heat loss through evaporation. Taking into consideration during the summer or even in the early spring and into the mid-fall, temperatures of 80 degrees with excessive physical exertion is not that uncommon in our area. So what do we do to treat heat exhaustion? Of course, We remove them from the environment, take them to a cooler place, and treat them for shock, him or her for shock. Unless the patient is unconscious, nauseated, or vomiting, we give fluids by the mouth, let them drink, sip cool water, not cold water, but cool water. We monitor their airway, their breathing, their circulation, and we arrange for transport to a medical facility. A little bit further down the line, we have heat stroke, and this is where it becomes a true medical emergency. This is when the body is subjected to more heat than it can tolerate, and normal mechanisms for getting rid of excessive heat, such as sweating, are overwhelmed. Patient's body temperature rises until it reaches a level at which brain damage can occur or does occur. Without prompt or proper treatment, a patient with heat stroke will die. Signs and symptoms of this include flushed, dry skin that feels hot to the touch. This is because the body has lost the ability to sweat. Altered mental status, verbal to unresponsive. They may be confused, disoriented, or they just may simply be unresponsive. Internal temperatures as high as 104 degrees Fahrenheit. So what about treatment? What can we do for these patients? First and foremost, we want to maintain their ABCs. Maintain they have a patent airway. Maintain that they have adequate breaths or respirations and good circulation. Remove the patient from the environment into a cool place as soon as possible. Remove their clothing down to their underwear. Soak the patient with water. Begin aggressive cooling of the patient with a hose, shower, or an ice packs, or sometimes even ice baths. One thing we don't want to do is put them in wet clothing, take their clothes off and put wet blankets or towels over top of them and leave them there, because this actually turns into a insulation barrier and will wind up trapping heat. You have a momentary cooling while that moisture or that fluid in those sheets are cold, but as soon as they absorb that temperature, they actually stop the transfer of heat. If the patient is conscious and not nauseated, administer small amounts of cool water if they're able to protect their own airway, and then arrange for rapid transport to an appropriate medical facility. So here's a table that compares heat exhaustion to heat stroke. Heat exhaustion, you'll have normal body temperatures, where heat stroke, your body temperature will be high or very elevated. Heat exhaustion, the patient will still sweat. Heat stroke, it is very usual that they have dry skin. In some cases, they will be still sweating, but it won't be effective. Heat exhaustion, they'll have cool and clammy skin, where heat stroke, it will be hot and red. Heat exhaustion, they'll be dizzy and nauseated. And then in heat stroke, they'll be semi-conscious, unconscious, or have an altered mental status. So flipping the coin from summer to winter, frostbite is a very common thing in the winter, and it results when an individual's extremities or certain parts of their body are exposed to a cold environment. Exposed body parts can actually freeze. The following body parts are the most susceptible to frostbite. You have your face, ears, fingers, and toes. People weakened by old age, medical conditions, exhaustion, or hunger are most susceptible, and people who have peripheral vascular disease, which decreases their peripheral circulation. Depending on temperature and wind velocity, frostbite can occur in a short period of time. Increases in wind speed have the same effect as decreases in temperature. This is called wind chill. Here on your screen you have a wind chill chart that's provided by NOAA. This is also in your textbook if you want to take an extended view to study it and try to make heads or tails of what it means. We have frost nip, or superficial frostbite. The affected body parts become numb and then turns bright red in color. Eventually, the area loses its colors and changes to a pale white. There may be a loss of feeling and sensation in the injured area. Treatment for this, warming a superficial frostbitten area or a part must be done quickly and carefully. Simply putting the fingers, toes, or ears next to a warm body part is enough. Do not try to warm a frostbitten area by rubbing it with your hands or a blanket, because this can cause cellular damage and further extend the injury. Looking at deep frostbite, the patient's skin will be white and waxy. The skin may be firm or frozen. Swelling and blisters may be present as well. If the skin has thawed, it may appear flushed with areas of purple and white, or it may be mottled or cyanotic. Treatment of this, always follow your scene size up, primary assessment and secondary assessment sequence. Remove any jewelry that the patient may be wearing and cover the extremity with dry clothing or dry dressings. Do not break the blisters. Do not rub the injured area. Do not apply heat or allow the patient to walk on the affected lower extremity or use an affected upper extremity. Provide prompt transport to a medical facility and treat all frostbitten patients for shock and hypothermia. Hypothermia occurs when the person's body temperature drops less than 95 degrees Fahrenheit. In hypothermia, a person's body is not able to produce enough energy to keep the internal or the core body temperature at a satisfactory level. People with inadequate or even wet clothing and those weakened by illness are the most susceptible to hypothermia. Intoxicated patients and patients who have abused drugs are at an especially high risk for developing hypothermia as well. Some of the signs and symptoms include feeling cold, shivering, decreased level of consciousness, sleepiness or drowsiness, lack of coordination, mental confusion, slowed reactions, as well as body temperature goes below 90 degrees Fahrenheit. The patient will lose consciousness and they will have a weak and very slow pulse. Sometimes you'll hear in reference to moderate hypothermia or mild hypothermia a term called the umbles, where the patient stumbles, they mumble, they grumble, and they bumble. These are precursors to severe hypothermia. The treatment for this, move the patient to a warm location. Again, get them out of that environment, separate them from the environment that's trying to kill them. Remove wet clothing, place warm blankets over and under the patient, insulate them from the ground, or from, if you're on a concrete floor, get them off the concrete floor. If you're out in the woods, get them off the dirt, get them off the rock, get them out of the creek. Insulate them and isolate them, remove them from that environment. If the patient is conscious, give them warm fluids to drink. Give them food to eat, small amounts of food to eat if they are able to protect their airway. The glucose in these things will help them generate heat. If you do not have access to a building, move the patient to a heated vehicle, if you have access to a heated vehicle. If transport is delayed or extended, you may need to use your own body heat to warm the patient. Handle the patient gently. Many hypothermic patients can go into cardiac dysrhythmias and go into acutely life-threatening cardiac conditions. Hypothermic patients must be examined by a physician. If a body's temperature falls less than 83 degrees Fahrenheit, the heart may stop and you will need to begin CPR. Always start CPR and use the AED if it's available. On hypothermic patients, even if you believe they have been dead for several hours, without a good history, we don't really know. Hypothermia patients should never be considered dead until they've been warmed in an appropriate medical facility and remain dead. That's to say, if we're simply presented with a patient in a cold environment with no history associated, that's when we're going to assume that this is an extended cold exposure and the result of the cardiac arrest is the cold environment. Each year in the United States, more than 3,500 people die from unintentional drowning, approximately 10 deaths per day. An additional 12,000 people are hospitalized because of injuries resulting from submersion in water. Drowning is the second leading cause of injury and death among children between 1 and 14 years of age. Alcohol consumption and drug abuse are contributing factors in many cases of drowning involving teenagers and adults. Drowning is defined as the process of experiencing respiratory impairment from suffocation or immersion in liquid. So this means you don't actually have to inhale water. If you are immersed in water and having a respiratory difficulty because of that, that is technically drowning. Submersion injuries result from being beneath the surface of the water or other liquid, and likely locations of drowning include streams, lakes, swimming pools, hot tubs, just to name a few. Wading pools, public fountains, and storm drain ponds. Hazards for drowning in infants and young children are presented in every household. Bathtubs, toilets, mop buckets. Young children can drown in liquids as shallow as 6 inches, sometimes even less. The process of drowning progresses through several stages. Usually the initial stage is panic as the person realizes that something is wrong. In other instances, the person becomes fatigued, injured, cold, or entangled in seaweed or kelp or some kind of submerged branches or strainers in the rivers, experience a loss of orientation, and they become ill. The feeling of panic produces an inefficient breathing pattern. If a swimmer is not able to take full breaths, the ability to float is lost and exhaustion sets in. Small quantities of water reaching the larynx or the voice box cause a spasm of the larynx, or the better known as laryngospasm, which makes it hard or impossible to breathe. In this cycle, if panic is not corrected, respiratory and cardiac arrest can result. Signs and symptoms of submersion injury include coughing, vomiting, difficulty breathing, respiratory arrest, cardiac arrest, broken bones or spinal injuries, and hypothermia when wet or in low air temperatures. For assessing your scene safety, if the patient is still in the water, do not exceed the limits of your training and attempt to rescue this individual. Keep yourself safe and attempt to rescue only if you can do so safely. Remember, reach, throw, row, and go. That sequence. Call for additional help because it will be needed. If there's evidence of trauma and you need to move the patient, do your best to protect their spine from further injury. Perform a primary assessment. Correct any airway, breathing, or circulation problems that you find first, and begin CPR if indicated. If a patient is breathing adequately, administer high-flow oxygen. And then as soon as the ABCs are stabilized or managed, dry the patient off. Cover the patient with towels or blankets to help preserve body temperature. Remember, even in the dead of summer, a submersion patient can become hypothermic rather quickly, or is probably already hypothermic or in a mild state of hypothermia. Obtain the patient's medical history from the patient if possible, or from any family members or friends that are present. Perform regular reassessments. And then all patients who have sustained a submersion injury should be examined by a physician. You should begin CPR on a drowning victim as long as they do not exhibit definitive signs of death, especially in cold water drownings. When a person is submerged in cold water, a protective mechanism called the mammalian diving reflex may be activated. This reflex slows the heart rate and the metabolic rate and decreases the body's demand for oxygen. There have been instances of survival of patients being submerged for over 30 minutes due to this reflex in cold water. When you encounter a person who has been submerged in cold water, even for an extended period, CPR should be started and continued until the person has been delivered to an appropriate medical facility. Okay, so talking about what comes from the sky, lightning injuries resulting from a lightning strike can cause cardiac arrest, cardiac irregularities, treatment of patients who have been struck by lightning by supporting the airway, breathing, and circulation. Oxygen administration, defibrillation, and CPR may be needed for some patients. Patients must be transported to an appropriate medical facility. Lightning injuries can also cause electrical burns. The type of burn is mainly internal, so the extent of the burn damage will not be visible right away after the injury occurs. Also, this is an instance where reverse triage, or a concept known as reverse triage, comes in play. If we respond to, say, a soccer field or a football field for a lightning strike and we have multiple individuals down and multiple individuals running around complaining of pain or broken legs, normally in a classic triage setting, we would go to the people who are still alive. involving a lightning strike, we're going to go to the people in cardiac arrest first and apply the AED and start CPR immediately. Because at that point, the heart is most likely in ventricular fibrillation due to the lightning strike. And if we can defibrillate that, we have a higher likelihood of saving those people from cardiac arrest. Bites and stings, sometimes classified as environmental injuries or discussed under the topic of poisoning. Bites. In this text, bites and stings, they are discussed in Chapter 11 under poisoning and substance abuse. So let's summarize what we just talked about in this chapter. Heat cramps are caused by electrolyte imbalance and dehydration. A person experiencing heat exhaustion sweats profusely and becomes lightheaded, dizzy, and nauseated. Heat stroke is a true medical emergency and results when a person has been in a hot environment for a long period of time, overwhelming the body's compensatory mechanisms. Body parts most susceptible to frostbite are the face, ears, fingers, and toes, especially when they're exposed to a cold environment. Hypothermia occurs when a person's body is not able to produce enough heat to keep the internal body temperature at a satisfactory level. Hypothermic patients should never be considered dead until they have been warmed in an appropriate medical facility. Drowning can occur in a variety of settings around home and outdoors. And lightning injuries are caused by a powerful jolt of electrical current that passes through part of the body. Okay, now we're going to do some review questions. Heat stroke occurs when A, outside temperature exceeds 90 degrees Fahrenheit. B, the body's heat eliminating mechanisms are overwhelmed. C, a person becomes dehydrated from excessive perspiration. Or D, the humidity exceeds 80%. The answer is going to be B. The body's heat eliminating mechanisms have been overwhelmed and can no longer compensate. Number 2, you are called to the scene of a patient with deep frostbite. Which of the following actions would be an appropriate action for you to take? Is it A, provide pain medication? B, rub the affected area to warm it up rapidly? C, arrange for prompt transport? Or D, apply heat directly to the damaged tissue? The correct answer is going to be C, arrange for prompt transport. In addition to that, we're going to cover those injuries with a dry dressing, lightly wrapped it to protect any blisters that may be present from rupturing. Question 3, when you encounter a person who has been submerged in cold water and is unresponsive, you should A, do nothing to the patient is already dead. B, transport him or her to the hospital because only physicians will be able to help this patient. C, warm the patient before taking any other action. Or D, start CPR immediately. Of the options given, it will be D is the most appropriate, start CPR immediately. Okay, that's all I have for you for Chapter 13, Environmental Emergencies. Up next, we will be covering Chapter 14, which is Bleeding and Shock and Hemorrhage Control. In the meantime, review your chapters in your books. Refer to your learning objectives for this chapter for study points. And if you have any questions or comments, please feel free to email me or drop me a direct message in the classroom chat. Until next time, thank you for your time.